All right. So for this final boss scenario, we are working at a festival.
Okay.
We are dispatched to a stage for a patient that climbed a speaker stand. So one of those, tall speaker stands in the crowd. And while they were trying to take a picture, they fell from the speaker stand.
Okay.
All right. So you are walking up. The police department is flagging you down, and they walk you up to a male patient that is currently laying supine.
Okay.
And you can go ahead and start. You can click that timer.
Good.
Perfect. Go ahead.
Okay. I have my BSI on, gloves and mask.
Okay.
Is the scene safe?
Your scene is safe. The police are there and making space for you.
Okay. Suspected mechanism of injury is the fall.
Okay.
Is it just the one patient?
Just one patient, yes.
Okay. We're going to go ahead and call ALS.
All right. ALS can
PD's
be...
already on scene.
ALS is working the festival as well. They are currently on the other side of the festival, so it's going to take them 10, 20 minutes to cart over.
Okay. I'll walk up to the patient and introduce myself. Say, I'm Dawson. I'm with EMS. What's your name?
Okay. You try to talk to him, but you get nothing back. He's just laying there.
I'll speak a little louder, tap him on the shoulders. Any response?
Still nothing so far.
Okay. I'll do a sternal rub.
All right. When you give him a sternal rub, he kind of moans in pain and rolls a little bit to the side, but doesn't talk back to you.
Okay. Do I get a general impression of age and weight?
Yeah, so he has a friend there with him that is super frantic and panicked, and she says his name is Steven. It's an 18-year-old male. It's their first time at a concert.
Okay. So responsive to verbal stimuli. It seems like the chief complaint is the fall. We're going to go ahead and start manual C-spine precautions. So I'm going to have my partner hold his head steady because we're worried about some head trauma with the fall.
Okay, sounds good.
And does the patient appear sick? I mean, they're unresponsive.
Yes, he looks pretty pale and sweaty.
Sorry.
You're good.
A little nervous. At this point, we have a high index for suspicion because the fall was significant.
Okay.
And we will... I think that's it. Yeah. So we're going to move on to the EABCs. So is there any life-threatening bleeds that we can see?
So you don't see any major bleeds currently.
Okay. How's his airway?
His airway is open.
There's no breath sounds or gurgling?
Nothing abnormal.
Okay.
No.
What about the tidal volume?
So your tidal volume is inadequate. He's breathing very slowly and shallowly.
Okay. So we're going to go ahead. Oh, we'll wait a second. How about accessory muscle use?
Yes, he's really working to breathe.
SpO2 and lung sounds?
His SpO2 is 83%.
Okay.
And when you listen to lung sounds, it is clear on the right, but diminished on the left while he's breathing.
Okay. So we are worried about pneumothorax at this point with the diminished lung sounds on the one side. So we're going to go ahead and start with BVM, but we're going to be careful not to be super forceful.
Okay. What liter per minute are we going to
15 liters per minute.
15?
We're going to provide some ventilations every 5 to 6 seconds.
Okay.
Do you want me to set up the oxygen?
Yeah, go for it.
Sure.
If you want to. I think we have everything.
So,
besides the BVM, can you just walk us through how to do it?
Sure. So we'll put on the regulator. Make sure that the holes line up with the prongs. And then make sure that you open the container. It seems to be open.
Beautiful.
I think it's empty.
And if we had a BVM, we would plug it up.
You would attach the hosing to the BVM.
Okay. Perfect.
Make sure you oxygenate it.
So our patient's now on oxygen. He's being bagged by your partner.
Yes.
And someone else is holding his head now. We have multiple people available.
Yeah. Make sure that we avoid the head tilt chin lift. We're going to be doing jaw thrust only because we're really concerned about the C-spine.
Okay.
Patient is in respiratory distress, close to or respiratory failure because it's inadequate and irregular.
Nice.
Just going to take some notes. And we'll move on to the circulatory conditions, skin, color, temperature, and moisture.
Sure. So your patient appears pale, He's pretty warm, but it's super hot out still. So we're at Lollapalooza,
Okay.
and they are diaphoretic.
Okay. Pulse, strength, rate, regularity, and equality.
Your pulse is weak, rapid, equal, and a regular pattern.
What about cap refill?
Cap refill is less than 2 currently.
Okay. So we've got a little bit of shock symptoms with the weak pulse and the pale skin. We're going to continue, I forgot to do the breathing treatment. Oh, no, we're doing a BVM.
He's on a BVM.
We're going to continue with the breathing treatment, and we're going to make sure that the patient is kept in a position of comfort. In this case, he's supine.
Okay.
And then if he starts to become cold, hypothermic, we'll make sure that he stays warm.
Okay.
Is there any consideration for hyperthermia at this time?
We'll say no.
Okay.
It's hot, but it's not super hot.
Okay. We'll probably start making our way to the tent anyway, just to get him out of the... Eventually.
Okay, I was going to say, should we move him yet? Or
Well,
should we...
eventually. I'm
Eventually,
just verbalizing that we're going to get him out of the warmth eventually. And we're going to expose the patient where necessary.
Okay.
We're going to do a full head to toe because we have a pretty high index of suspicion.
Sounds good. Where do we want to start?
We'll start with the head. So any decap, BTLS, deformities, contusions, abrasions, avulsions, penetrations, burns, tenderness, laceration, and swelling, and bleeding.
Okay, so there is a contusion to the back left of the head.
Okay.
No active bleeding from that site. Nothing else to note for decap BTLS on the head right now.
Okay. Is there any bleeding around the eyes or behind the ears, raccoon eyes or battle sign?
There are battle signs present
Okay.
behind the ears.
Any CSF, cerebral spinal fluid from the ears or nose?
There's just blood coming out of the ears and the nose. Good check. No CSF.
Okay. And how's the mouth? Is there any blood in the mouth? Any teeth missing? Do I smell anything?
Mouth is still clear. You don't smell anything abnormal.
Okay. And we're going to check the eyes. How are the eyes?
Okay. Your pupils are unequal.
Unequal. Okay. All right. And we'll palpate, starting at the face, for any deformity, instability, tenderness, or...
All right. When you palpate, you feel crepitus upon the back of the head, like the back left, kind of where the contusion was. Nowhere else.
Okay. Okay, well, we'll move on to the neck.
All right.
Decap, BTLS, and bleeding for the neck.
There is none to note.
Okay. Is there any jugular vein distension?
No.
Any subcutaneous emphysema?
No subcutaneous emphysema.
Tracheal deviation?
No. Trachea is still in line.
Okay, we're going to palpate the cervical spine for any deformities to make sure that it's in line, any tenderness or crepitus.
Okay, it's in line. You don't notice anything abnormal.
Okay, we're still going to apply a C-collar at this point to the patient.
Okay. Could you just walk me through how you would do that? You don't have to put it on because we have the headsets on.
Sure.
But just what you would do.
With the AMBU C-collar, you're going to take a measurement from the patient's shoulder to the line of their mandible or their chin.
Okay.
And you're going to take the same amount. I don't know what the best angle is.
You're good.
You're going to take the same amount of fingers, say we used 4, and you're going to place it under the black line here.
Okay.
And then you're going to make sure that this second bit of plastic here is in line with your fingers. So this is a little short.
Perfect. It's definitely a hard spot for a lot of students. So always good to go back over that.
Yeah. So here we're good. And you got to make sure that you lock it in. You'll have your partner maintain the manual stabilization, and you'll kind of slide it under their neck. You want to make sure that you flip this part out. You'll slide it under, and then you'll secure it. You want to make sure that there is no gaps between the shoulders. And
C-collar is applied.
Cool.
Good job.
And that
Good
there's
explanation.
no like, the head is not flexed.
Yes.
Okay. To
Onwards.
the chest. Any decap, BTLS, or bleeding for the chest.
You notice some contusions, like bruising, to the left shoulder and the left side of the body, like right here. No bleeding. I don't know if you said that or not, but no bleeding on the chest either.
Is it discoloration?
Yep, just discoloration.
Okay. Is there any sucking chest wounds?
No.
Any subcutaneous emphysema?
None.
Any paradoxical movement, flail chest?
No signs of flail chest.
Okay.
The breathing's just shallow.
Still with the BVM?
It's working with the BVM.
Okay.
Yeah.
Everything else is fine with the BVM. We're managing
Yes. I meant him breathing on his own.
Okay.
Shallow.
Cool.
Sorry.
How about lung sounds? Are they?
It's the same, diminished on the left, clear on the right.
Okay. And then we are going to palpate the shoulders, the clavicle, the sternum, and the ribs for any deformity, instability, crepitus, or tenderness.
Okay. You don't notice anything abnormal.
Okay.
It feels stable.
Okay. We'll move down to the abdomen. Any decap BTLS for the abdomen?
None.
No? Okay. Any evisceration?
No evisceration.
Cullen sign, Gray Sterner sign, discoloration around the umbilicus or the flanks?
There is a little bit of bruising to the flanks that you can note.
Bilaterally or
side.
just on the left?
Just on the left.
Okay. We're going to palpate all four quadrants of the abdomen for any tenderness, rebound tenderness, rigidity, or unusual masses.
Feels like a normal abdomen.
Okay.
Feels stable.
Nothing notable.
Soft.
We'll move down to the pelvis, decap, BTLS, or bleeding for the pelvis.
Okay. There is none visible.
Okay. Is there any priapism?
No.
Okay. We're going to push down and in for any instability.
You don't
tenderness,
know
crepitus.
Anything abnormal there.
Okay.
Feels stable.
We'll move down to the lower extremities.
Okay.
Any decap, BTLS, or bleeding for the lower extremities?
So there's a deformity to the left ankle. It's super swollen. Looks like that's where he landed.
Okay. We will hold off on splinting until we are either in transport.
There's probably other things to worry about.
It's important to not delay transport with
Yeah.
splinting. So we'll hold off for a second.
Okay.
We'll assess PMS if possible.
All right. There's a pulse on both legs.
Okay. Is it equal?
Yes.
Okay. And then is there any motor or sensory sensation?
He still isn't really working with you. He's just
Okay.
still kind of knocked out.
Okay. And then we'll palpate kind of offset down the limb to see if we can feel any instability, feel any crepitus.
Okay. You just note some crepitus around the left ankle.
Okay.
Some cracking when you push on it.
Okay. We'll move up to the upper extremities. Same idea.
Okay.
Decap, BTLS, or bleeding for the upper extremities.
There's just some scrapes and bruising on the left arm.
Okay.
But no major bleeding or anything to note.
Okay. And then we'll also check pulse. He's not working with us, so motor and sensory is
Okay. There's
moot.
a pulse present in both arms. It's still equal.
Okay. And then we'll palpate as well for any instability, crepitus,
Okay.
tenderness, deformity.
Nothing abnormal on the arms with palpation.
Okay. We will ensure that we're maintaining, well, he's got the C-collar on now, but make sure that we're trying to maintain some stability with the spine, and we'll log roll him so that we can check the back for decap, BTLS, and bleeding.
Okay. When you log roll, you just see some bruising on the left side of the upper back.
Okay.
No bleeding, nothing else to note besides that.
Okay. Is there any sucking chest wound?
No.
Any subcutaneous emphysema?
None.
Okay. And then we will palpate down the C-spine for any instability, any crepitus.
Okay, it's stable and inline.
Down the spine and the ribs.
Nothing to note.
Okay. So we will transfer the patient to the backboard.
Okay.
We'll hold off on splinting because the patient's unconscious and we're on the backboard now. We have a high transport priority because we're worried about the unresponsiveness and also the unequal pupils.
Mm-hmm.
I don't know what else. So you said his friend is on scene with us?
Yeah, he's still with you.
Okay.
It's a girl.
Okay.
Sorry. Yes.
So we'll ask to see if we can get some medical history from the friend on scene.
Okay. What do you want to know?
Onset, it seems like it was sudden.
I would skip that section, so just do sample. Just because he's unconscious, so we're not going to get much from it.
Sure.
But
does he have any allergies, any known allergies to food or medication?
So the friend says no allergies. He doesn't take any medications either.
Okay.
As far as we know.
Does he have any medical history?
He just has asthma. That's all I really know about him.
Okay. What about last oral intake?
Well, we were just trying to have a good time, so we took a couple pills probably like an hour or two ago.
Okay.
And we haven't eaten since breakfast, which was like a long time ago.
Okay. Do you know what the pills were?
No, we just got it from like one of my friends. It was like a little circular pill, and we both took it.
Okay. And what was going on before your friend fell?
Well, he was kind of acting weird. Then I saw him run and climb the stand, and he said he wanted to get a better view, and that was the last thing that I saw of him. Then he just fell down, and we called you guys for help. So.
Gotcha. Okay. Can I have the vitals, please? BP?
Your blood pressure is 160/80.
Okay. Pulse rate?
Pulse rate, it's around 50.
Vent rate with BVM, probably.
It's controlled with the BVM. We'll say it's like 12 to 14 breaths.
Okay. Pupils?
Still unequal.
Still unequal. Unequal how? Or is one dilated or?
The left side's dilated, yeah.
Okay.
The right side is fixed and kind of like constricted.
Kind of constricted or pinpoint?
Not pinpoint. Okay. Not pinpoint.
Okay.
Just smaller than the left.
Sure. Okay. And then blood sugar?
You get 62 back.
62. Okay. And then SpO2. Is it improved?
Your SpO2 is sitting around like 92, 93 right now.
Okay. So the 63 blood sugar is something that is low. So we can go ahead and administer some. We're going to want to do IM glucagon. It's 1 milligram because the patient is unable to follow commands.
Okay. What other things would you want to check for, say, like another focus? What are you thinking?
We checked for. Is there any drug or alcohol paraphernalia that's around?
No.
It's mostly unknown.
Not around.
Okay. The pupils are not pinpoint.
I guess you can't really do much because he is unconscious.
I'm not sure. Well, we would go through kind of like a neurological focused assessment.
Okay, yeah.
So
that's what I was looking for. I was just making sure.
Yeah, there's not a lot of questions that we can ask. So you would ask about headache, blurred vision, any drugs or alcohol, obvious injury.
Yeah. I think you've covered most of the ones that you can do, so that's okay. Yeah.
The patient is not having an active seizure. There's no bleeding in the mouth, so we're not concerned about a seizure.
Okay.
No naloxone administration because it's not indicated. Though I suppose it wouldn't hurt. There's a lot of reasons why he could be breathing inadequately. The pupils are not constricted. Are the friend's pupils constricted?
No.
No? Okay. So I think that's okay. We'll go to the reassessment. We're going to make sure that we're reassessing the patient every 5 minutes to note no significant changes to the ABCs or the primary. Because the patient's unconscious, we want to make sure that we are monitoring all of the vitals to make sure that nothing crashes.
All right.
And we're going to make sure that we're checking the overall condition and our interventions.
Okay, so
we'll take another sugar.
Sugar's gone up. We'll say it's at like 86 to 90 now. While we are en route to the hospital, since you were the first one on scene, they have you go in the ambulance. We note that our patient is, our friend that's bagging him, it's getting a lot harder.
Okay.
And he's getting a lot more pale. Our patient is, not the EMT. Yeah. I should know. So
he's freaking out because it's not working.
Yeah.
So we're going to go ahead and try to administer a supraglottic airway, the eye gel.
Okay. Could you walk me through?
Yeah. Do we have a general sense on the weight of the patient?
We'll say he's like 170, 180 pounds. Okay. That's a good guess.
So that's going to be the size 4. Well, it's close.
How would you know? Just for the people watching at home.
So it's weight-based. So the size 3 is 30 to 60 kilograms. And the size 4 here says 50 to 90 kilograms. So 60 kilograms is a little bit above 120 pounds. So he's definitely above that. We're going to make sure that we have our lubrication, and we're going to lube the applicator and make sure that we're applying the lubrication to the back and not the front so that we get a good seal.
Okay.
You'll open the patient's mouth with the scissor technique and the tongue and jaw lift, and you'll make sure that the opening is facing anteriorly so that it's toward the trachea.
Throat, yeah.
Toward the throat,
Okay.
yeah. And you'll insert until you meet definitive resistance.
Okay.
And once you've inserted, you'll switch the bag over to this, not before placing the colorimeter. And after you begin ventilating with the supraglottic airway, you want to make sure that you can see condensation.
Keep going, you're good.
Condensation in the airway.
Deep, so.
Yeah,
okay.
Condensation in the airway. You want to make sure that you're getting adequate chest rise and fall.
Mm-hmm.
You're going to listen to the lung sounds to make sure that they are as present as they were before, and that you hear no epigastric sounds.
All right. What else should be getting better?
Yeah, the SpO2 and the skin conditions should improve.
Okay.
So we're
That's
going to
what I was
monitor the
looking
SpO2 and the skin conditions.
All right.
And we'll tape it down too. But
that was good, yeah. And just for the grand finale, your partner says, "Oh shit, we lost a pulse. What do we do?"
So we're going to begin.
He's freaking out.
We're going to begin CPR immediately. So we're going to make sure that our hands are in the lower half of the sternum.
Okay.
Making sure that we're going at least 2 inches deep at about 120 compressions per minute. And then we'll have somebody go and grab the AED. So as soon as the AED is on scene, you discontinue compressions. You apply the AED to the right upper shoulder and the left flank, just below the pectoral.
Yeah.
And then the AED will analyze the rhythm to see if a shock is necessary. And then what's important with the advanced airway is that you can give continuous ventilations through CPR.
That's a great note to put in there. Yeah. So that's pretty much everything. We'll say we're about to pull up to the hospital. We'll say that we got a pulse back. All
Okay.
right. So what are you going to tell the nurse or doc when you walk in? So we'll say that like the trauma room.
Yeah.
'cause
Well,
it's trauma.
the first thing that we'll say is, like, we responded to the festival for the somewhat unresponsive patient, 18-year-old male. Upon en route to the hospital, the patient fully arrested. We have since achieved ROSC with the AED. Upon arrival, we found the patient responsive to painful stimuli. I think, yeah. Responsive to painful stimuli, breathing inadequately and irregularly. SpO2 is 83. Lung sounds were diminished on the left. We went ahead and bagged the patient. SpO2 improved to about 92, 93. Upon assessment, we found contusions to the posterior head and crepitus around the contusion. We did find battle signs behind the ears and some blood from the ears. No significant findings with the neck, but we did apply a C-collar. Moving down to the chest, there was discoloration on the left shoulder and the left flank. No notable deformity or crepitus. We did continue to hear diminished left lung sounds on the left. The patient has a deformity with crepitus to the left ankle and scrapes on the left arm and the left side of the chest, the abdomen.
Yeah.
No significant findings on the back other than continuation of the discoloration on the left flank. Pulses were present in all extremities. Patient has no known allergies, not taking any medications currently. History of asthma. The patient didn't technically admit to taking pills, but patient took pills of unknown origin at the festival about
an hour or two
yeah. before we were on scene. BP is 160/80. Pulse is 50. We're bagging at 12 to 14 breaths per minute. The pupils are unequal. I missed that one with the head. Blood sugar was 62, so we went ahead and administered 1 milligram of glucagon IM. Sugars improved to 86. Do you have any questions or orders?
No? Yeah, so let's just take a minute.
Yeah.
Settle.
I feel like that was a lot.
It was a lot. I think that if I was proctoring and this was the final, you would have passed. I think we were only out of time because I kept throwing more things at you.
No, that's okay.
And also asking you to like show the camera how to do a C-collar.
No, I was stressed too, so yeah, I hesitated a little bit.
I think you did really well. This is a great example of what you should be able to do on a final exam. Sure. I think the big thing that we do with this final boss is kind of try to throw you in a situation that's like a oh shit moment.
Yeah.
And I mean, you handled it pretty well. So
I appreciate that.
Your head to toe was great. The only notes I had was I don't really think that we needed to give this patient like sugar. You know, like it wasn't needed, but
62 is low.
It's a little bit low, but there's other things going on that we're worried about.
Sure.
We also can't really check if it works. I guess like we could get another blood sugar to see that it rises, but they're not really AMS. They're just, you know, unconscious.
Well, I just didn't know. We weren't present on scene before the fall, so it's possible that the patient could have, you know. Yeah,
but that was my one really note. I mean, besides that, when you're going into the hospital and giving that report, they want short and brief, but that will come with time.
Yeah. It was one of my longer reports. I think being thorough is
good.
Yeah.
But just in real life, the doctor will be like, okay, so do they have a pulse? What were the last vitals, right? Things like that.
Sure.
But yeah. Do you have any questions about that scenario?
No.
I think I'd have to tweak it a little bit. There were a couple things.
Yeah. But. Well, I was expecting something with medical. And so the pill was like, oh, okay, here it is. But then there was no need for naloxone. So.
Yeah, I'm pretty sure the one thing I would have tweaked was I would have had the friend say around the start, like, oh, we took these pills. Because I don't think it was obvious that neuro was the choice besides the pupils being unequal, but that could have been from the fall as well.
I think that might have influenced my decision to give the glucagon too, because I was looking for a reason to go there.
Yeah.
So.
Well, even...
Were you doing Cushing's triad?
No.
Low pulse.
Oh, it was a low pulse, yeah. I wasn't really thinking of that, but I did a high blood pressure too.
Yeah,
I guess it could have been Cushing's triad.
Yeah. I think I missed that.
I guess they were also bleeding from the head, but I didn't say it was just blood, not the CSF.
That's a good note.
That's I should add that if I ever do this scenario again. Thanks, Vic. But yeah, now that we're done with the scenario, just a couple podcast questions. This is my podcast now. Thanks, Vic, for the gear. So when you were taking this class and you first started, so let's say you were walking in today for your first day.
Sure.
What would you tell new students to do, to do as well as you just did on the final?
Sure.
Right? Like if it was their first day, they're just coming in, like, this is what I would do, advice or study tips, things like that.
Absolutely. I think that the most important thing, most important piece of advice that I could give to a new student here is to really take it seriously. I think there were a lot of people in our class that didn't and definitely saw some repercussions. Beyond that, I mean, you got to really give it a good go around. You need to study. You can't just coast in this class.
Yeah.
Try to be as proactive
and present. I think is a good way. Yeah.
As be willing to put yourself out there is something that I've learned. There's a lot of physical in this class, and it can be very vulnerable to put yourself in a position where people are watching you do something. Mm-hmm. I think it's important to try to get over that quickly.
Yeah. I think one thing that's really big with that too, that I notice with new students, is that they're kind of scared to practice skills or do eye gels and things like that. But it's like, it is hard, and we want you guys to practice it here. So when you're in the field, it's like, it's common sense, and it feels natural. Yeah. Right. So that's a good
especially
tip.
one of the first labs where we
especially
did the
start,
CPR training.
We don't know people.
There was a lot of hesitation.
Yeah.
And I think that the folks that are ready to act and ready to go, and they're the ones that are going to do the best.
Yeah. Yeah. All right, that was a good answer. So, question 2, it's kind of similar. What went well for you in this class? Like, what did you do to do well?
My situation is a little bit unique because this is kind of the only thing that I had going on for this semester.
Yeah. So you're not in college or anything?
I'm on a leave of absence for this semester.
Okay.
For
I was going to say.
some familial reasons.
Okay.
But it ended up working out really well. doing this and that concurrently because I got to give this my focused effort. I tried to make it to all the office hours that I could. And I think just being around and being present in this environment was really helpful for me. It helped me to continue to understand how serious I needed to take it. And I think, kind of like what Sarah said, is actually doing the studying. There's a lot of studying that is not required for your grade, but I think that it'll really help you get comfortable with the material. And then, you're investing. If you spend a lot of time studying, then you won't have to study as much for the final.
Yes, that's a good point, I think, too. Sorry, I keep adding notes, but
no, it's okay.
I think that most students, when they start the class and you don't study hard in the beginning, they don't realize that the class is just going to keep building. Yeah. Right? It's kind of like a pyramid. Like each unit, we add more, but the old stuff doesn't go away. It's your foundation.
Yeah.
So yeah, that's a good answer.
And it's really important not to drop off with your intensity either.
Yeah. I think it's also helpful that you don't have a lot of other things going on because most students that struggle are ones that are in college where they're balancing finals and their practicals, right? Or coming
I
to
can't
class
speak
after.
to time management like that.
It's tough.
But, it's definitely hard.
Yeah. Okay, one last question, and then we are done. If you could change one thing about the class, what would you change? Whether it's content, how we teach, lectures, labs.
Yeah,
if there's anything.
I've talked with Mo a little bit about this, and I don't intend to throw anybody under the bus or put anybody in the spotlight, but
it's okay.
I think one of the only comments that I had about the way that the class is taught is that there were times where maybe some of the information transmitted from the instructors was unequal.
Yeah.
So there were some groups that got some information that other groups didn't, and then there were other groups that, maybe didn't get through the lesson that day, or I don't know that there's a really great way to solve that.
It's very hard to be perfect.
The fact that my point is so nitpicky says a lot about the program and the way that it's run.
Yeah.
I think that they're doing a really great job.
Awesome. Yeah. Well, if you don't have anything else, shout out to all of our wonderful students and instructors.
Yeah. And thanks to Vic and Marty for the experience. It's been one of the best of my life so far.